I think it'll depend upon, a lot will depend upon the nature of the approval in the U.S., whether it's going to be a broad approval or a narrow approval based on the type of tumor the patient has in terms of, it's expensive therapy. So access to care will be an issue. And so that was going to impose a limitation on everybody. But then how it gets sorted out, once it's available to us, I think it's going to be very institutionally dependent upon the skill sets that are available. We have therapies that we've done for decades, like embolization. I mean, 90% of the patients with neuroendocrine tumors get liver metastases, and they mostly die from liver failure. That's the major organ at risk. So controlling the liver is kind of paramount for long-term survival. My mother, who was an interventional radiologist, embolized carcinoid mets in the liver. I mean, this has been going on for half a century. So it's a very well-established therapy, and it's so well-established that it's actually never been subjected to prospective trials. So now you have PRT, which of course has had a nice randomized controlled trial to get approved in the U.S., very high level of evidence. But that level 1 evidence is comparing it to octreotide, not comparing it to another predicate therapy like embolization. So how it's going to shake out depending upon people's biases relative to levels of evidence versus what the goal in the patient is, I think it's a very, very practical question, and it's going to be debated a lot in the next couple of years.